In today's quiz, we will explore drugs used in the management of heart failure. The quiz features 10 multiple-choice, scenario-type questions designed to test and enhance your understanding of the topic. Each question offers 5 options, along with detailed explanations for the correct answer and insights into why the other options are incorrect. Be sure to check out the companion video linked in the description for an overview of the key concepts related to heart failure medications. So, let's get started. Question 1. Mr. Johnson, a 55-year-old male with heart failure with reduced ejection fraction, hypertension, and chronic atrial fibrillation, presents with worsening heart failure symptoms despite being on optimal therapy with carvedilol, lisinopril, and furosemide. Which of the following medications is contraindicated in a patient with heart failure due to its negative impact on mortality? Option A, metoprolol succinate. Option B, diltiazem. Option C, bisoprolol. Option D, sacubitril/valsartan. Option E, ivabradine. The correct answer is option B, diltiazem. The explanation is as follows. Diltiazem, a non-dihydropyridine calcium channel blocker, is contraindicated in heart failure with reduced ejection fraction as it can depress myocardial contractility, worsening the condition and increasing mortality risk. This medication should be avoided in heart failure with reduced ejection fraction patients to prevent negative cardiovascular outcomes. Here is why other options are incorrect. Option A is incorrect because metoprolol succinate is a beta blocker proven to reduce mortality in heart failure with reduced ejection fraction. Option C is incorrect because bisoprolol is another beta blocker that is beneficial in managing heart failure with reduced ejection fraction and improving survival. Option D is incorrect because sacubitril/valsartan, an ARNI, is a cornerstone therapy for heart failure with reduced ejection fraction with mortality benefits. Option E is incorrect because ivabradine reduces heart rate and has shown to decrease hospitalization risk in selected heart failure with reduced ejection fraction patients. Question 2. Mrs. Davis, a 68-year-old female with preserved ejection fraction heart failure, presents with worsening dyspnea and fatigue. She has a history of hypertension and chronic kidney disease, CKD, stage 3. Which of the following classes of drugs is most appropriate for initial management to reduce hospitalization risk in heart failure with preserved ejection fraction? Option A, beta blockers. Option B, loop diuretics. Option C, mineralocorticoid receptor antagonists. Option D, SGLT2 inhibitors. Option E, ACE inhibitors. The correct answer is option D, SGLT2 inhibitors. The explanation is as follows. SGLT2 inhibitors, such as empagliflozin and dapagliflozin, are effective in reducing hospitalization risk in patients with heart failure with preserved ejection fraction, regardless of diabetes status. These medications offer cardiovascular and renal benefits, making them a preferred choice in heart failure with preserved ejection fraction with chronic kidney disease. Here is the explanation for incorrect options. Option A is incorrect because beta blockers are more beneficial in heart failure with reduced ejection fraction and are not first line for heart failure with preserved ejection fraction. Option B is incorrect because loop diuretics help control symptoms of fluid overload but do not reduce hospitalization risk. Option C is incorrect because mineralocorticoid receptor antagonists are effective but not superior to SGLT2 inhibitors in reducing hospitalization. Option E is incorrect because ACE inhibitors have limited evidence for reducing hospitalization risk in heart failure with preserved ejection fraction compared to SGLT2 inhibitors. Question 3. Mrs. Foster, a 50-year-old female, presents with fatigue and palpitations. She is newly diagnosed with heart failure with reduced ejection fraction and started on a beta blocker. Which of the following beta blockers is not indicated for heart failure management? Option A, carvedilol. Option B, bisoprolol. Option C, atenolol. Option D, metoprolol succinate. Option E, nebivolol. The correct answer is option C, atenolol. The explanation is as follows. Atenolol is not approved for managing heart failure with reduced ejection fraction as it lacks evidence for reducing mortality and improving outcomes in heart failure patients. Guideline-directed beta blockers like carvedilol, bisoprolol, and metoprolol succinate are recommended instead. Here is the explanation for incorrect options. Option A is incorrect because carvedilol improves survival and reduces hospitalizations in heart failure with reduced ejection fraction. Option B is incorrect because bisoprolol is a beta blocker with proven mortality benefits in heart failure with reduced ejection fraction. Option D is incorrect because metoprolol succinate is the recommended beta blocker formulation for heart failure with reduced ejection fraction. Option E is incorrect because nebivolol is sometimes used in elderly heart failure with reduced ejection fraction patients but still has less robust evidence compared to other options. Question 4. Mr. Gibson, a 70-year-old male with heart failure with reduced ejection fraction, is admitted with decompensated heart failure. His current medications include furosemide, carvedilol, and digoxin. Intravenous milrinone is initiated. Which of the following is the primary mechanism of action of milrinone? Option A, inhibits sodium and potassium ATPase pump. Option B, inhibits phosphodiesterase 3. Option C, blocks beta-adrenergic receptors. Option D, enhances calcium reuptake in sarcoplasmic reticulum. Option E, blocks angiotensin II receptors. The correct answer is option B, inhibits phosphodiesterase 3. The explanation is as follows: milrinone inhibits phosphodiesterase 3, leading to increased intracellular cyclic AMP levels. This enhances myocardial contractility and causes vasodilation, making it beneficial in acute decompensated heart failure. Here is the explanation for incorrect options. Option A is incorrect because sodium and potassium ATPase pump inhibition describes digoxin's mechanism, not milrinone. Option C is incorrect because milrinone does not block beta-adrenergic receptors, beta blockers do. Option D is incorrect because enhancing calcium reuptake is the mechanism of SERCA activators, not milrinone. Option E is incorrect because blocking angiotensin II receptors is the mechanism of ARBs, not milrinone. Question 5. Mr. Irwin, a 45-year-old male with acute heart failure and cardiogenic shock, is started on intravenous dobutamine. Which of the following is the primary indication for dobutamine in this setting? Option A, increase systemic vascular resistance. Option B, decrease pulmonary congestion. Option C, improve renal perfusion. Option D, enhance myocardial contractility. Option E, reduce myocardial oxygen demand. The correct answer is option D, enhance myocardial contractility. The explanation is as follows: dobutamine is a beta-adrenergic agonist that increases myocardial contractility by stimulating beta-1 receptors. This makes it effective in managing cardiogenic shock to improve cardiac output. Here is the explanation for incorrect options. Option A is incorrect because dobutamine decreases systemic vascular resistance, not increases it. Option B is incorrect because reducing pulmonary congestion is a secondary effect, not the primary action. Option C is incorrect because renal perfusion improves as a result of increased cardiac output, not directly. Option E is incorrect because dobutamine may increase myocardial oxygen demand, not reduce it. Question 6. Mrs. Jackson, a 58-year-old female with heart failure with reduced ejection fraction, is being counseled on medications contraindicated in pregnancy due to potential teratogenic effects. Which of the following drugs is contraindicated during pregnancy? Option A, spironolactone. Option B, metoprolol. Option C, valsartan. Option D, furosemide. Option E, digoxin. The correct answer is option C, valsartan. The explanation is as follows: valsartan, an angiotensin receptor blocker, is contraindicated during pregnancy due to its teratogenic effects, including fetal renal dysfunction, oligohydramnios, and skull hypoplasia. These risks are most significant during the second and third trimesters of pregnancy. Here is the explanation for incorrect options. Option A is incorrect because spironolactone, though not first line, has no established teratogenic effects. Option B is incorrect because metoprolol is generally considered safe during pregnancy, particularly for managing hypertension. Option D is incorrect because furosemide is not teratogenic, though it is used cautiously in pregnancy due to its diuretic effects. Option E is incorrect because digoxin is not known to cause fetal harm and can be used in specific heart conditions during pregnancy. Question 7. Mr. Anderson, a 60-year-old male with recently diagnosed heart failure with reduced ejection fraction, presents for heart failure management. His baseline heart rate is 80 beats per minute, and his blood pressure is 118/72 mm mercury. Which of the following medications has been shown to reduce heart rate without affecting blood pressure significantly? Option A, carvedilol. Option B, metoprolol tartrate. Option C, ivabradine. Option D, digoxin. Option E, sacubitril/valsartan. The correct answer is option C, ivabradine. The explanation is as follows. Ivabradine selectively inhibits the funny current, IF, in the sinoatrial node, reducing heart rate without affecting blood pressure. This makes it particularly useful for heart failure patients with elevated heart rates but stable blood pressure. Here is the explanation for incorrect options. Option A is incorrect because carvedilol, a beta blocker, reduces both heart rate and blood pressure. Option B is incorrect because metoprolol tartrate also lowers both heart rate and blood pressure. Option D is incorrect because digoxin slows heart rate by increasing vagal tone but is primarily used for rate control and atrial fibrillation. Option E is incorrect because sacubitril/valsartan primarily reduces blood pressure through its vasodilatory effects and does not directly reduce heart rate. Question 8. Mrs. Wilson, a 58-year-old female with newly diagnosed heart failure with reduced ejection fraction, is being started on sacubitril/valsartan. What mechanism of action best explains the benefit of sacubitril in heart failure? Option A, inhibits neprilysin, leading to increased natriuretic peptides. Option B, blocks angiotensin II receptors. Option C, inhibits sodium-potassium ATPase pump. Option D, blocks L-type calcium channels. Option E, stimulates beta-1 adrenergic receptors. The correct answer is option A, inhibits neprilysin, leading to increased natriuretic peptides. The explanation is as follows. Sacubitril is a neprilysin inhibitor that enhances the activity of natriuretic peptides, leading to vasodilation, natriuresis, and inhibition of the renin-angiotensin-aldosterone system. This mechanism significantly improves outcomes in heart failure patients. Here is the explanation for incorrect options. Option B is incorrect because blocking angiotensin II receptors is the role of valsartan, not sacubitril. Option C is incorrect because sodium-potassium ATPase pump inhibition is the mechanism of digoxin. Option D is incorrect because L-type calcium channel blockers are not used in heart failure with reduced ejection fraction. Option E is incorrect because beta-1 adrenergic receptor stimulation would worsen heart failure. Question 9. Mrs. Adams, a 62-year-old female with heart failure and poorly controlled diabetes, presents with persistent lower extremity swelling despite optimized diuretic therapy. She is currently taking metformin, lisinopril, carvedilol, and furosemide. Which drug class has been shown to provide mortality benefit in heart failure with reduced ejection fraction? Option A, calcium channel blockers. Option B, sodium glucose cotransporter 2 inhibitors. Option C, loop diuretics. Option D, thiazide diuretics. Option E, digoxin. The correct answer is option B, sodium glucose cotransporter 2 inhibitors, SGLT2 inhibitors. The explanation is as follows. SGLT2 inhibitors, such as dapagliflozin and empagliflozin, improve outcomes in heart failure with reduced ejection fraction by reducing hospitalization and mortality through mechanisms like diuresis, improved cardiac metabolism, and reduced inflammation. Here is the explanation for incorrect options. Option A is incorrect because calcium channel blockers are not indicated in heart failure with reduced ejection fraction and may worsen symptoms. Option C is incorrect because loop diuretics alleviate symptoms but do not reduce mortality and may worsen symptoms. Option D is incorrect because thiazide diuretics are not first line in heart failure with reduced ejection fraction and lack mortality benefit. Option E is incorrect because digoxin improves symptoms but does not reduce mortality. Question 10. Mr. Garcia, a 45-year-old male with heart failure with reduced ejection fraction and a history of gout, is being treated with carvedilol and furosemide. He presents with recurrent gout flares. Which of the following medications is most likely contributing to his gout attacks? Option A, carvedilol.
Option B, furosemide. Option C, spironolactone. Option D, digoxin. Option E, sacubitril/valsartan. The correct answer is option B, furosemide. The explanation is as follows. Furosemide increases uric acid reabsorption in the renal tubules, predisposing patients to hyperuricemia and gout attacks. This side effect is common with loop diuretics. Here is the explanation for incorrect options. Option A is incorrect because carvedilol does not affect uric acid levels. Option C is incorrect because spironolactone has minimal impact on uric acid metabolism. Option D is incorrect because digoxin does not interfere with uric acid levels. Option E is incorrect because sacubitril/valsartan does not increase uric acid levels. Conclusion. That wraps up our revision on heart failure medication. I hope you found this quiz session engaging and informative. To deepen your knowledge further, consider reading resources like Katzung and Trevor's Clinical Pharmacology, Rang and Dale's Pharmacology, and the British National Formulary, BNF. These references will solidify your understanding and enhance your preparation. Also take note that in this video, any mention of guidelines will specifically refer to those outlined in the BNF. Thanks for watching. If you found this video helpful, don't forget to give it a thumbs up and share it with others. Subscribe to this channel and hit the notification bell so you never miss an update in the series that we are doing. For more learning resources, check the description below. See you in the next video.